Seizures. Did I encounter this often? Yes, especially febrile seizures. Also, seizures are often found in a developmentally delayed or with some kind of chronic disability. You might get a page from the nurse on the third floor that your patient is having a seizure. You run up, you encounter the patient, and sure enough, they may be in status epilepticus right in front of you. So what does a patient who's having a seizure look like? It's convulsions, eyes rolling back, often a loss of consciousness. That's your typical seizure. Or they may be in a postictal state, a little bit confused, maybe drowsy because they had a seizure. So now it's time to get a history from the patient who's had a seizure. What do you want to know? Is it their first seizure? Was the seizure witnessed? Are they on any anti-seizure medications? Also, you may want to ask if they have any residual deficits, weakness in one arm or another, any inability to speak correctly. You really want to make sure that they didn't have a stroke. During the physical exam, the neurological portion is one of the most important. So make sure to check all the cranial nerves, and you want to do a reflex test. The reflexes are easy to remember because over the Achilles heel you have S1, S2. Over the patellar region you have L3, L4. Then you have over the biceps region C5, C6, and then the triceps C7, C8. 1, 2, 3, 4, 5, 6, 7, 8. So what are the labs that you want to order on a patient who has just had a seizure? You definitely want to get a stat glucose. Make sure this patient isn't a diabetic with a hypoglycemic episode resulting in a seizure. Second of all, you want to get a CBC. Yes, they'll have an elevated white blood cell count from falling on the floor and having a convulsion, but if it's markedly high, you may want to suspect meningitis. Then you'll also want to get a complete metabolic panel and look for any electrolyte abnormalities. And then if they're already on a seizure medication, depending on what they're on, you may want to check a level. And also, depending on what kind of population you work with, you may want to do a drug test to see if any illicit drugs could be the culprit here. As far as imaging goes, you're getting a CT to rule out something else happening here, an acute bleed. And then if the seizures continue to recur, you may want to get an MRI. That's more of an outpatient order, however. So after that initial workup in the ED, you're going to want to order two things. One, an EEG, and two, a neurology consult. Let's talk about the normal adult EEG. Awake, you're going to have beta waves. Eyes closed, alpha waves. When a patient eventually starts to fall asleep, the alpha waves will dissipate and give way to theta waves. Sleep spindles form, delta waves come up, and finally, in REM sleep, back to beta waves. The same waves you had when the patient was awake. Partial seizures. They're either going to be simple or complex. And what makes them complex? Loss of consciousness. Epilepsy, or status epilepticus, defined as a seizure lasting more than 30 minutes. Tumors can cause seizures, fevers can cause seizures, strokes can cause seizures, infection can cause seizures, benzodiazepine withdrawals can cause seizures. There are also generalized seizures. Absence seizures, classically found in young children, where they seem to be just staring off into space. Know that this produces a 3 Hertz spike on EEG. There's myoclonic, grand mal seizures, tonic seizures, and atonic seizures. Myoclonic seizures are when the muscles stiffen. Tonic-clonic or grand mal seizures is when the muscles stiffen and relax, stiffen and relax, stiffen and relax. Tonic seizures is a stiffening, and atonic seizures is a complete relaxation. It's also known as a drop seizure. As far as treatment goes, you don't start treatment on the first seizure unless there is a high risk of recurrence, like the patient had a grand mal seizure, or there's a strong family predisposition to seizures, or the EEG shows some kind of obvious abnormality, or maybe the patient unfortunately does have a tumor. Now, what if the patient on the third floor is in status epilepticus? What are you going to do? Well, you want to administer a benzodiazepine a few times. And then if that doesn't work, you can go ahead and move to the next drug, which would be phenytoin. The treatment for absence seizures, the seizures little kids get when they're staring off into space, well, that's easy because for a little kid to have a seizure sucks. So the treatment is ethosuximide. Ethosuximide blocks calcium channels. Patients with grand mal seizures, they need valproic acid, which increases GABA. And finally, one of the most common things of all, the parents who bring in their infant child who's had a febrile seizure. And the typical age is between 12 and 18 months. A single seizure within 24 hours is reassuring, but the risk of a recurring seizure is as high as 50%. There is no need to do a lumbar puncture on these kids, but they do have a higher chance of developing epilepsy at an older age. So I always recommend that parents treat fevers with acetaminophen, but studies don't show that this actually prevents future febrile seizures from occurring.